I want to share a few thoughts about our curriculum. I think that it is really important as all of you tour programs across the country virtually, albeit this year, that you take time to understand the goals of the curricula at each of these programs. We have very specific goals. The first goal is clinical skill. We have a goal that everyone who finishes our program will be an outstanding clinician. The forces in academic medicine today create distance between you and our patients. And in fact, obviously the COVID pandemic has created even more distance and even more challenge for us to maintain bedside presence with our patients and teaching at the bedside. So we are incredibly deliberate about ensuring that everyone that finishes our program understands, learns, and values bedside medicine. So the way to do that is pretty simple, is to keep you at the bedside. So our interns own the care of every patient that they have admitted to their service. We do this here by emphasizing this in the internship year. Many people use the word autonomy for our program. I don't think that's the right word. The right word for our program is ownership. What does happen in our program is that interns have ownership. And I believe that is essential to learning clinical skill. It's like any other art or skill that you would ever want to master. And you know, it is impossible to master anything if you try to do it at an arm's length. You must immerse yourself. And so for us, we believe that has to happen immediately when you begin training. So as an intern, it is true that you will own the care for every patient that is admitted to your service. How do we do that? We do that by making sure that the intern is the primary provider for all of our patients. So if a nurse ever has a question about one of the patients on our service, they will call the intern, not the senior resident and not the attending. If you have a consultation for one of your patients and you happen to call the chair of cardiology, that chair of cardiology will call the intern to say, thank you for letting me participate in the care of your patient. These are my thoughts. They will not call the senior resident. They will not call the ACS or the attending. And that's because it is your patient as an intern. If there's a patient that's admitted to your service, you will get the call from the emergency room. You'll be the first person to go downstairs to the emergency room and evaluate the patient. If the patient has shortness of breath, you will be the first one to take the history. You'll be the first one to examine the patient. You'll be the first one to think about what you think is going on, create an assessment plan. You then call your resident. The resident happens to know already that this patient is there and understands what the illness is and what we should do, but you are calling them to inform them with your assessment and plan. And that is the formative piece, that you are taking the time to make that initial assessment and plan. You're not being told what to do for this patient, but you are developing that plan on your own. And you may say that I believe that this patient has an acute exacerbation of asthma. We should put them on this floor in the hospital and we should do A, B, and C. And immediately that resident will start to say, well, I agree with you on the demographic of the patient, but I think that they actually have decompensated heart failure and they need to go to this floor in the hospital and that we need to do X, Y, and Z, not A, B, and C. Immediately the learning begins. But the learning only happens because you have taken ownership of trying to develop your own assessment and plan and being accountable for the care of that patient.